We need so many people who have a deep commitment to education because that way folks are able to empower themselves to make better choices. Practical knowledge of having an addiction specialist be present through this program empowered other physicians and treaters to better take care of our patients. We made that goal get to abstinence because that might not be the person's goal. But what we are going to do is help you live a more optimal life. We can't expect folks to be knowledgeable, empowered, and feel like I know what I'm doing if they don't have access to the information. But to your point, and what we were able to show is once they have access to that education, they will easily take on that opportunity.
Good afternoon, Dr. Yana, and how are you?
I am well. I'm excited to be here.
I'm so excited to have you here. Thank you so much for agreeing to come. Yeah, I know you're very busy, so I appreciate you coming.
Yes.
And joining us, on what would be the series of episodes for the Transforming Minds.
Tell me about it. Like, how did it come about? What is your vision? I'm so excited.
I am a resident in New York and currently PGY3. I am highly interested in addiction, psychiatry, and I happen to be highly favored and blessed to be awarded the National Medical Association and the National Institute of Drug Abuse Award. And part of the award-winning project, I did propose to educate and do that through disseminating literature that's out there.
I love this for you. Congratulations.
Thank you.
First of all, addiction is such a great field, truly. I buy it. And we need so many people who have a deep commitment to education because that way folks are able to empower themselves to make better choices. I love this.
Oh, thank you so much. When I was proposing it, it was very important for me because I work in a community setting, and a lot of the primary care providers, residents, even psychiatry residents, in programs that are community-based that wasn't really addiction geared, didn't have the knowledge, but we were seeing a lot of people. So I happen to be in Staten Island. It's one of the smallest boroughs in New York, but has very high rates of overdose deaths. At one point, it was number 2. Yeah. So for me, I was like, if I'm going to trade in the community, what's the way I could give back? When I think about the people that I look up to that are in this place, I couldn't think of anyone but the Dr. Yana Jordan.
Oh my gosh.
At the Transform Minds, we really hope to explore intersection between mental health. Like I mentioned, our main focus is on substance abuse and addiction. Unfortunately, sometimes that's seen in a different light for mental health. And I want even the people that are in the profession to see it as more than just behavioral. There's all these different aspects to it. There's all these different systematic ways that we can impact the people that are affected. One of the ways we're going to do that today is to talk about bridging the gap and trying to integrate addiction care into community mental health.
Yes.
And Dr. Rihanna is an amazing researcher. I look up to her. Dr. Rihanna Jordan, she is an MD PhD. That means she's adapted that. She took the extra step and dedication to get more expertise in the area of research. And we do appreciate that because we do need more people.
Thank you so much. And anything that I can do, truly, like to support you in that journey, absolutely. And you don't have to go and do the MD PhD program, although you want 5, but you're a residency. However, really thinking about your research matters, right? And so let's do it.
Yeah. Definitely. Dr. Yamana is the now Barbara Wilson Associate Professor in the Department of Psychiatry, Addiction Psychiatrist, and Associate Professor in the Department of Population Health at New York University Grossman School of Medicine. As the principal investigator for Jordan Wellness Collaborative, she leads research, education, and clinical program that partners with community members to provide optimal access to evidence-based treatments for racial and ethnic minoritized patients. Well, through her multifaceted work, she provides addiction treatment in 6 sites I truly believe I'm in the spaces that I'm in, and I've been very grateful to be here because of God. So when you think of transform life, I want you to think about the ways that faith and spirituality plays a role in your addiction and all of those spaces at transforming first of mind. Yeah, so this makes me so excited to have her. She also studies outcomes for people with opioid use disorder in carceral system and trains addiction specialists to provide cultural informed treatment, which is also another reason why she's here to train all of us, including me. And Dr. Jordan is dedicated to creating spaces and opportunities for more people of color, specifically Black women in academia who are vastly underrepresented. She has been featured at international conferences and is proud recipient of various clinical research awards. Recently, Dr. Jordan received the prestigious Presidential Career Award for Scientists and Engineers, the highest honor given by the U.S. government to early career scientists and engineers. So we're gonna pause and clap stats bigs. Congratulations. Oh wait.
Hey, that was really nice. Yeah, I got a lot of awards, but that was like amazing when President Biden gave me that award because it's like, wow, the president is paying attention. So I appreciate that.
That's amazing. And we all do appreciate work you're doing for our community. Thank you. Do you have anything you want to say?
No, it's like, what is the intro? I'm in the right place.
I am so happy to have you here. Big shout out to Dr. Hurst. Connected BTU, yes.
Thank you, Danny. Adopting Danny. Thanks for the connection.
It's been very monumental in all of this. As I mentioned earlier, the title of this episode is Bridget the Gap, Integrated Addiction Care into Community Mental Health. And this was picked because of Dr. Ayana's research that she has done. And that research was basically integrating ambulatory addiction consultation service into community mental health center. And that resonated really well with me. As someone that, like I said, I work in community setting. Okay, I see a lot of people that need services. And currently in this space, we do need a little bit more knowledge, a little bit more skill to help the people that need it because they may not have the resources. Yeah, so before we start, I'll give a quick summary about the actual study and then we'll go into a few high points and we'll have some questions for Dr. Jordan to talk about it. Great. So this study actually discusses the implementation and the outcomes of addiction consultation service. It focused on basically integrating that addiction specialist into outpatient psychiatric care. I currently work in outpatients. We do have the addiction clinic in the building, but it's not really integrated. So I think the integrated model is amazing.
Yeah.
Some of the high points really was focused on the prevalence of substance use, really among the clients that were being seen. Also the integrated model, which was improved, and we would love to hear all about that. And it's very timely and it increased access. So that's what everyone that's listening, if you work in a setting, you would think about integrated that.
Yeah, absolutely. Yeah, that was a wonderful overview. And I think what you said is really important around the numbers. A lot of folks say, hey, I don't want to do addiction. That's over there. Let me take care of my patients with schizophrenia, bipolar disorder. And what you were able to note from the paper that you published was there's a huge overlap. And actually, it is over 50%. So there's no such thing as you're a patient, an addiction patient, because we have to work together in order to treat the whole person. And so because of the lack of training that's in a lot of our programs, and also the prioritization of what matters in house of medicine, addiction is always at the bottom a lot of times. And medical students and trainees, they don't learn how to take care of people with substance use disorders with the most relevant evidence-based care. And so one of the ways that we're able to address that is by modeling how easy it is to address addiction in these spaces. And we have to start in the community. Folks will come in for depression, anxiety. They might even come to their primary care for hypertension. And we can take advantage of the opportunity to treat them for their alcohol use disorder, tobacco use disorder. So thank you so much. Because look at the paper. You could do this. It's not rocket science. You can start a program like this in your community setting. So this is how. I mean, you were able to show benefit
with this program. Yeah. Could you tell us about the benefits that you saw when you were to the program?
Yeah. First thing is that one, it was dual. Because a lot of times people are like, oh, we have to form a committee and it takes years and we're to get this implemented. And we found that wasn't the case. There was a lot of resistance, not because physicians, other mental health practitioners in the clinic didn't want to do that. They were just overburdened and they were not feeling empowered. They felt like they didn't know enough. So they didn't want to do any harm. And what we found is by providing education, right? We're here. If you have any questions, we can easily answer them. We're available to you that they were more likely to address the needs of patients with co-occurring disorders because they knew that there was somebody that had their back to answer any questions. So that was one. Practical knowledge of having an addiction specialist be present through this program empowered other physicians and treaters to better take care of our patients. That was one. The second thing is that we actually bridged that gap. So there was no more, okay, a patient has to go to you for their depression and to me for their overuse disorder. We were able to show that the patient can go to the primary treater for both. And what we did was a very easy one-page proposal. What do you need help with and how can help you? And so we would review through the help of a nurse, triage, what are the most pressing ones, which actually need expert consultation, and which can we just answer really quickly. And that way we were able to say, okay, these are the ones that are really simple. We can settle a plan and they can be treated. And these are the ones that may have to come into our program, right, for a short amount of time so that we can get them started on the treatment plan. And then we were able to transition them back. So we were able to actually bridge that gap. They didn't have to go to another place. They didn't have to have a wait list. A lot of times people have to wait 6 months, 7 months before they even see an addiction specialist.
Yeah, that's a long way. It is. I did one month in addiction clinic, and people have to wait a really long time, unfortunately. And you mentioned a few things that I want to highlight. And the first one was you spoke about the gap that's there. People didn't feel confident with. So this year, actually, the QI project, which assessed the residents and some of the healthcare professionals in my hospital to see how much they view. Because I looked at the entire hospital data and I found that most of the people that actually come in for addiction ended up in medical unit. So I wanted to see their knowledge and how much they knew about addiction. But a lot of them didn't feel confident, but they were the ones that were caring for it. So part of the QI prep was to educate them in different ways. It's not the easiest ways they could care and provide even resources in the community. So it's amazing that you have all of this out there, evidence-based research, and a lot of people don't even know it.
They have no clue. And I love that you did that QI project. And I actually got surprised in terms of the low level of literacy that folks have because it goes back to it's not integrated in our education.
Yes.
So we can't expect folks to be knowledgeable, empowered, and feel like I know what I'm doing if they don't have access to the information. But to your point, and what we were able to show is once they have access to that education, once they have someone with that training that's willing to help, they will easily take on that opportunity to help because we all want to help our patients. And so I love that. I love that you were able to do that QI project. And that's why what you're doing here is so important through education. And so one of the things that is important is just to let people know we had medication for addiction treatment. They exist. Less than 20% of those medications for addiction treatment are utilized, which is ridiculous, especially because they work better than some of our high blood pressure medications, some of our diabetes medications. Yet many people are on those, but they're not on medication for addiction treatment. So that's first. let's use what we have. We actually don't need to embed anything new right now. Let's use what we have because the MNT or the numbers needed to treat are quite low in terms of how many people do we need to treat in order to see benefit. And for these medications for addiction treatment, it's low. Once we were able to show, okay, these are the medications early addiction treatment, these are how they work, people were willing to use them. They're super safe. They're more safe than Tylenol. We give people Tylenol all the time. They go take Tylenol over the counter. So we're like, it's not a matter of risk. It's just a matter of people don't know how to use them. But once we started them, saw that the patients were doing better, they were like, we could do this. So that's really awesome. Yeah.
You make it so easy. And I know it most likely because you are an expert in the field. And we would love to have you come back to teach more about how to use some of these. Like, let's and I love that you already started teaching. So what I wanted to do for our next segment is talk a little bit about a case. That's the case, yes. And then we'll see a few questions based on the case, and that could be a form of education for every. That's all right. So, have Maria, who is a 34-year-old female with a history of schizoaffective disorder and opioid use disorder. She had long-standing psychiatric care, no structured addiction treatment. Recently, she was hospitalized for a fentanyl overdose and seen in outpatient Ballor. Behavioral health team initiates a referral to an integrated addiction consultation services. So, our first question: what are some of the challenges in treating a co-occurring disease within patients like Maria?
Yeah, I think one of the first things that we can all agree is that Maria's case is actually not uncommon, right? We see a lot of people who have serious mental illness that are also misusing substances, and in our current landscape, it's opioids, either intentionally or unintentionally. But to get to your question on what the challenge is just getting buy-in that there actually is a problem. Many folks are like, I'm good. I don't have a problem at all. And so there's very limited insight into the substance use disorder itself. Very first thing is to get on the same page. What are the goals of what we want to accomplish, right? And sometimes people are, and we have to be okay, but this is where safety optimization or harm reduction comes into play with the person may not be at a place where they actually want to acknowledge that they have a problem or do anything about it. So then the goals of care have to be to support the patient in their own goal. If someone is at least willing to acknowledge that there's a problem, then we can move amongst the spectrum of what we can do and intervene. But even if they're not the place, we can use tools which are so awesome to improve their understanding of what's happening. So that's when things like motivational interviewing really comes into play. So it's like, what is this fancy name? It's just a way to increase awareness and create discrepancy within the patient. This is where you want your life to be. This is where you are. What is stopping you from getting to where you want your life to be? And MI allows for that awareness and improves change talk where the patient, like in our case, we may say, hey, I'm not able to go back to school. I'm not able to just live a life that's free of chaos. And one of the ways that I might be able to do that is to minimize my opioid use. So, first problem, improving insight. Yeah, super common. And MI is a tool that allows us to improve that insight and help the patient see that their substance use might be a reason for them not getting to their goals.
No, that's absolutely amazing. And it's true for motivation to be it. Most people may not utilize it or may not think about it. There's so many papers, research, literature out there that shows the helps support people. And it's funny you brought this up because I've been looking a lot more into harm reduction. That wouldn't be like the harm reductive success guy. Yes, because they're not ready, but you're also not pushing them to the complete abstinence art where you're working with them to get this buy-in. And at some point, there is that change, and they hold through that stages of change as they get to the point you actually help them. I would be presenting the big word hibernation. Friday, women see how it worked for them.
That's amazing.
Yeah, on Monday. I think it's great, like all these things, and I'm like, I'm not here trying to be like that for you. So the next question, actually, we want to know, like, how does my same day appointments actually help with engagement, vacation?
Yeah, I mean, you can imagine what you talked about earlier in the show is around barriers, right? And beyond like money, you can't necessarily get people to have money, but what we can do is make it easier for them to access care, right? And so I was come to the clinic and they would turn people away because they're like, oh, you were late for your appointment. Or they would say, this person was a no show, so they can't come anymore. And we would never say to somebody like, your sugar levels are increasingly high, so you can't be seen here anymore. It's that is a nature of the illness itself. People are going to be chaotic in their views that they may not come to their appointments. So how can we make it easier for people to show up for us to treat? So one of the things that we do in integrate the addiction clinic and primary care services was just have open access. So there were days where we had an addiction specialist out there scheduled for the entire day that the whole purpose is for you to see people say, oh, so there was no need for an appointment. People didn't have to be late, right? Yeah, because we're here. And as long as you show up, we're going to see you on the same day. Oftentimes, we really work to treat you on the same day. So sometimes, a lot of times, the model is fill out all these forms. Then you have to wait to see a doctor after you see a clinician first. And it's no, see a doctor immediately. We're available to you. How can they get the blood work, everything, so that if we do need to start a medication, we can. Oftentimes, we don't even have to start a medication. We can do behavioral intervention. So the setup was really having people show up and having a doctor available on days. So we eliminated the unnecessary barriers. And that was huge because what we saw is that not only did patients come, guess who else came? Doctors, social workers, nurses. They say, oh, Dr. Jordan, I had this case. Can you help? So we were always busy, and it wasn't necessarily for direct patient care, but that's important, but for other mental health professionals who needed help and they know they were available, right? So they didn't have to wait for a referral system for us to get back. Come, ask us. Yeah.
Yeah, that's amazing. That's urgent care service. Anyone to come in, and
Anybody should come.
anybody can, even a little bit more than that. There was that consultative service for other professionals
Right there, right there.
And that's amazing, especially you know there's so many people in waiting months to get services. And sometimes that can be the end will be all for people.
Especially because you want to take advantage of when people are ready, right? So yes, if you on a Tuesday goes, okay, I want to stop in Maria's case, opiate use now, and then you don't get an appointment for 10 days later, what if that motivation has now waned? We missed the opportunity to strike while the person was ready. And so just how transformative was that in terms of having that open clinic model? And it was shared understanding. Listen, if we're busy, you may have to wait, but that's okay because your bonds get seen.
So what I'm hearing you say right now is have that open window of opportunity and use that. Because you're going to miss someone, yes, and you don't want to do that, especially in someone that's going through different stages of, I don't know, I'm contemplating, do I want to change? Do I want to stop using this? If they're coming to you, that least they're at that point, and it's great to have that open arm for them, that open space, that good if they're waiting a few hours.
And oftentimes they would have to wait a few hours. It might be like an hour or maybe minutes, but they would be seen.
Oh, that's amazing. And you talked about like berries. Like that was one of my next questions. What are some of the berries that would be experienced in a case like Bree?
Oh gosh, so many. First, as we all, and this is the general in terms of just mental health, is like stigma. Folks don't want to be labeled as an addict. So that's a word I would never use. There's a lot of work that has shown that using words like addict, abuse, substance abuse, actually is more likely for folks to be treated negatively in the system. So David Filene and colleagues at Yale, they said, like, how does language impact not only how medical providers treat patients, but how patients think about themselves? And so one of the things that we've done to try and address that barrier of stigma is really use person-centered language. I always say a call in, that call out. Even when I get consultations by well-intended colleagues and they'll be like, okay, I have a person with substance abuse, I'll say, oh, let me do a call in right there. I want to use substance use disorder because just having that language improves the likelihood that person will be cared for in a more humane way. So that's first. Another thing is when the patient comes in, I am here to help in whatever you want to do. So I normalize addiction care. To your point, we made that goal get to abstinence because that might not be the person's goal. But what we are going to do is help you live a more optimal life so we minimize your risk of death. And everybody wants to get around that, right? So in the case of Maria, sometimes I want to stop using this because I don't look like my somebody, right? I want to be beautiful. I want my face full again, right? I want to be fabulous. And I'm like, all right, let's do it. So what are ways that we get by in that way? Also, we just talked about, like, how can we make it so that if you do choose to use something right now, understanding that you want to stop it, that you're not increasing your risk of death. So we're able to get things like naloxone, right?
I always have Relaxa home. Always. Then it's how you she was a really an addiction psychiatrist.
We're in the middle of the overdose crisis. So this is the Connecticut Harm Reduction Alliance, and I do some research with the CTHRA. So the point in that we have naloxone, and this is a medication that can reverse opioid overdose. And I love it because it comes in different formulations. You can do intranasally, which is what I have here. Fancy way to say it goes in your nose, right? You can do it intravenously, which goes inside your vein. And you can do it intramuscularly, so it can go through the muscle. I have all three. This is the easiest. A lot of folks know about this. And so what you do, that there's a pink plunger here, you insert it into the nostril of the person who has the overdose, and you just push the plunger up and it delivers the spray. All right. And it's so easy to use. So Maria, I make sure that she has access to naloxone. So she will not even leave without having that. And I just say, you'd be surprised at how many people don't even know it exists. Or their doctors have never given it to them. Or they've never received information. So one of the things that I'll say is, like, whether Maria was stopped, whether she's been stigmatized or not, I'm like, you're not leaving here without naloxone, and I'm going to teach you how to use it so that you can teach anybody else how to use it. And that's one of the ways that we've been able to intervene. So that's really awesome. So barriers, let's destigmatize it, empower folks. You want folks who are dealing with substance use disorder to feel like there is something that they can do, that their life is worth living, that their goals are for, you want to be fabulous? Let me help you be fabulous, because we know the opioid's killing you. So those are some things that we are able to do. Yeah.
It's amazing she carries that around. And she didn't mention the naloxone. It's very important. And I just want to remind folks, like, if you don't know how to use this, as Dr. Jordan said, just push in your nose, just make sure it's all the way up in there so it doesn't go to the wrong places. You actually deliver it. Also, just remember, if you're giving it to someone else outside, once you give it, you have to call 911 and take a step away, because sometimes it can be this person you don't know. It's a stranger that you give it something to, so you have to give them space once you administer it and get them space to wake up. Make sure you call 911 or support after that.
Perfect. Yeah.
That's amazing. And we do acknowledge all these barriers, and amazing. He does like everything we're talking about. I'm like working on something that's breaking. It's just so basically, I gave him a whole lecture about language, and I'm like, no, Now abuser, person that uses drugs, that's different thing. So it's amazing sometimes, even the people that work in our field, how they see people that use the substances, how they treat them. So it's amazing to hear you just talk about all of this. I'm like, okay, well, the right where you are at, I'm taking the right thing. So it's amazing. The last question about Maria is, how do we ensure that there's continuity in care? So once they leave, that's not it, and they're actually continuing with that care.
This, I think, is the perfect way of modeling the impact of the integrated addiction clinic within the primary care setting, because Maria's already coming to the clinic for her schizoaffective disorder. So we are not adding yet an additional barrier, her having to see yet another person. We're simplifying because we're saying, let us start medication for addiction treatment once Maria gets there. And there's 3 options available that are FDA approved. We can do Suboxone or buprenorphine, that's the generic. We can do methadone, or we can do naltrexone. 3 FDA approved medications for opioid use disorder. So that's important. And once we start Maria on those medications, our primary person can continue all of them except methadone, because methadone is the one medication that you have to get at a specialized place called an opioid treatment program, or OTP. But the good news is that my lab is actually working on a research project within the clinical trials network under NIDA that is looking at providing methadone in primary care set. Oh, that's so people don't have to go to an OTP. That would be so great. We are going to see that in our lifetime, because we're going to show you can do it. It's easy, and we actually don't want to push people to areas that there might be high crime, high substance use that's not good for the recovery. In terms of continuity of care, what we're able to do is simplify the regimen. So we start, because that's the biggest thing. Sometimes I don't know how to start. We start it, we educate the primary physician, and we say, Maria, go back to the person who's getting you your medications, who's taking care of your schizoaffective disorder, and they can do everything there. And then what we say, if, how you doing 6 months later, right? So people know that we're just not, see you back, all right? Because a lot of time on the consult service, it's like, that's what it is. Yeah. You don't see it anymore, right? But for here, we're saying we're in an outpatient setting. We are here to help. And so we check in proactively after 6 months. How's Maria doing? Do you have any questions? Are there any adjustments that need to be made? And we make it easy for folks to continue care. Because that's the goals. We don't want to complicate. We don't want to create more barriers. And very soon, so bite me that. I know you're ready to don't wait you idea. We're going to talk about our methodology here in the.
Oh my God, that'll be amazing, because I was just looking at some work, and I was like, sometimes the way methodology is delivered feels very carceral. And I'm not get percept like it shouldn't feel that way. I try to distinguish that. Oh,
you got it. So that's what you were talking about on the bio. Is one of the things we realize is like we cannot perpetuate systems that make folks feel like they're doing something that's crazy, right? So we want to humanize, which goes back to address another barrier, is making people feel like they're getting treatment in a positive way.
So that's really quiet. Do you guys hear those? Like, do you went up here? This is what, like, it's amazing. She's done all this great work to make sure that people are not just educated, but those receiving the treatment are also receiving very evidence-based treatment that's been tested. So if you are a healthcare professional out there, an ally professional, whatever field you're in, the mental health services and addiction services, that's some of our work. And that's a trip. At Dr. I have enjoyed it on all the socials. Yeah, amazing. So before we close out, I just wanted to give you the opportunity to, first, if I wear, or any of us that are listening to you, what will be a clinical pearl out of your personal experience, expertise, but also out of this paper that you've spoken about, and that you would give us? What is one thing that we should take away?
Do something. You do not have to be an addiction specialist in order to treat someone with a substance use disorder, right?
Yes.
In a way that as medical professionals, everybody does CPR in the house of medicine. That's what we're going to do. In the same way, do something. You can't refer someone to an addiction specialist. You can teach someone about naloxone. You can read the paper and figure out who are the key stakeholders to replicate a program like this and then primary care setting. You can learn the motivational interviewing so you can use open-ended questions, affirmations, reflections, summarizing to get someone along the recovery journey. But it's not okay to do nothing. You have to do something. And it's available to us. We also have free education modules through Coursera and PCSS, right, through the American Academy of Addiction Psychiatry, that provides easy ways for you to understand. So it's not an excuse. I didn't learn enough to go. I didn't learn the rest of the seat. It's free and it's available. Do something.
That's amazing. I'm like literally soaking it all in. So for those of you that you heard, she literally quickly went over the core principles of motivation interviewing. So if you didn't hear it and you were like, oh, I skipped over it, just go to Google, put in motivational interview and put OARS. OARX. And you will get that and look it up. Look open-ended. A lot of us learn this in medical school, in nursing school, all of that. Affirming patient, we do all of this, and sometimes we forget to use them. So practice makes perfect, and we all do all skis all the time. You would practice with your family.
Not only are you like so gorgeous, so stylish, but super knowledgeable, and I always say like, I can rest easy. The future is better. So thank you for your work and thank you for this platform.
No, thank you so much for being someone that we can look up to someone that I can see myself in and say, these are the things I'm interested in. I see someone that looks like me. Those that don't know, Dr. Hannah also will chair and is a director of REACH, which is a substance use program. People that look like all of us.
Yeah.
That are interested.
You're going to be a REACH scholar because that's what we do. How do we train folks that are from racial and ethnic minoritized backgrounds in culturally important addiction treatment? So part 2.
Part 2 is coming. Yeah. But please, is there anything you want to leave us with? A little thing you want to talk about?
No, we've done it. I just say keep on doing the good work. We know that it's difficult times, but we persist. And so I'm really happy.
Thank you. And you all help me say thank you to Dr. Jordan. Please visit our social media. Say thank you. We appreciate her for coming. Thank you so much.
Beautiful.